All right, hello all. Welcome to our second session on the Improvement and Innovation Showcase on Think Sepsis, Improving Care and Saving Lives. Before we get started, I'd just like to acknowledge that today we meet on the traditional lands. I'm meeting on the traditional lands of the Kaurna people. I'd like to just say that we respect their cultural connection with their country, both now and in the past and into the future. And I'd also like to acknowledge that others may be meeting with us on other lands of other people. Before we start, just a little bit of housekeeping. This session has been preset to keep your mics on mute and your video turned off by default. However, we'll be enabling this during the Q&A time after the presentation. Only the presentation will be recorded and published, so the recording will be stopped for question time. Just before the Q&A, there'll be a quick survey for you to complete. We'd appreciate you taking just a minute to complete this to assist us with the evaluation of today's event and see if we're meeting your expectations and how we might be able to do things better. For the Q&A, we'd really love to see your smiling faces, so if you could turn on your mics and use the chat function to ask your question. I'm sure our presenters today would be really happy to talk about their passions. So this is a bit of a selfless plug for us here. If you're unfamiliar with the CIH, which is the Commission on Excellence and Innovation in Health, we're the lead agency for innovation in healthcare in South Australia. And we love to bring consumers, clinicians and other collaborators together to turn ideas into better healthcare. Our vision is, as it's on the screen, together creating health and prosperity for all. To do this, we're supporting the sector to come together to imagine new ideas for better healthcare. We also acknowledge that better isn't always excellent, but we're committed to measuring what we are doing so we can understand the impact the change is having. So what if the big idea was connecting all the small ideas? This is the essence of why we host these improvement and innovation showcases, helping to connect people in South Australia and across our sector, providing a space to explore what others have learned. It's all about sharing ideas, improvements and innovations. So we have a sort of a series of season sessions that are approximately 40 minutes and available online at any time. We aim to keep it simple and share work happening across the sector at any stage or level of success, not really waiting until the work is complete and ready to be published. We focus on work in South Australia, but every now and again we share the showcase outside our state to ignite ideas. So just a quick prompt here as well. If you have a problem or have had success in solving a problem, whether you've learned something or trying to solve a problem or anything else you think that we should explore, we would love for you to get in touch with us via the email displayed. And we'd like to hear if you have that story to tell. So this is the second episode of that series of showcases. Our theme for the showcase is sepsis, improving care and saving lives. Sepsis is a life-threatening complication of infection and can affect people of any age. Early recognition is critical, and the sooner sepsis is identified, the sooner life-saving treatment can begin. Early detection can reduce complications, shorten hospital stays, and improve survival. Sepsis is one of the CIH's priority focus area projects under the Clinical Excellence and Safety theme. Over the next few years, we'll be concentrating our efforts with delivery partners to improve mortality and morbidity from sepsis. So how we got here. Sepsis was chosen as a clinical priority for a number of reasons. One is the parallel process of bringing together the efforts from the HCEC safety and quality decision to focus on unwanted clinical variation, where they endorsed sepsis improvement as a system-wide focus. And in parallel, the HCEC Clinical Council, which also prioritised clinical excellence and safety, which has led us to really focus on sepsis so that we can align our efforts, resources, and activate system capacity. So the CIH has begun work to understand the burden of sepsis in South Australia. As a first step, we replicated the analysis from the Australian Commission on Safety and Quality in Healthcare Sepsis Epidemiology Report, that's a long word, that reported that approximately about 84,000 sepsis cases across Australia. In South Australia, we found that there's been about 6,400 in 24-25 with an explicit ICD-10-AM diagnosis. And although it's a relatively small number of admissions, around 17 a day across our sites, there's a very high mortality and long length of stay in ICU utilisation with those who do have sepsis. And for those that do survive, recovery often involves long-term physical, cognitive and psychological challenges. And as part of our commitment to sepsis being our priority focus area, we have 4 sessions over the next month to connect, share and explore experiences. Throughout the series, we'll hear from a range of speakers who share their insights. So last week, we heard about grassroots strategies to improve regional sepsis response from Funland, and also a consumer experience with that. If you've missed that one, it'll be published shortly on our website. Next week, we'll hear from Western Australian Department of Health, who will discuss the current state and future directions for sepsis data in Western Australia. And on the 26th of March, we'll hear about strengthening sepsis survivorship and best practice care from Dr. Jacob Dye and sepsis survivor Fiona Gray. So which leads us on to the topic we're going to speak to and our speakers today. So our speakers today are for Andrew Bersten and Lyn Whiteway. Andrew is an intensive care specialist at the Flinders Medical Centre and is currently the Executive Director of Research at SALHN. He has led ICU clinical services across SALHN, authored around 200 publications, and edited multiple editions of O's Intensive Care Manual. His current work focuses on improving sepsis care through data-driven quality improvement, using a learning health system approach. Joining him is Lyn, a health consumer advisor with lived experience of sepsis and over 20 years experience in consumer representation. She is the co-chair of the SNAP Consumer Advisory Group and represents consumers on the SNAP Global Trial Steering Committee. Together, they bring both clinical and consumer perspectives on improving sepsis care. So without further ado, I'll pass over to our first speaker, which is Andrew.
Thanks very much, Lisa. It's a great pleasure to be here, and thanks for the opportunity to share some thoughts with you. Just as I start, I'd also like to acknowledge that, I'm meeting on Kaurna land as well today and pay my respects to Kaurna people and all other Aboriginal peoples of the lands people are on in this discussion today. What I'm going to do is, here's an overview of what I'm going to try to do, and I'm going to talk about what is sepsis and try to understand that, and talk about some learnings that I've had over many years, but have really been focused probably in the last 18 months as we started to try to understand how we measure things a bit better, talk about why it's important. How would we know if we were improving, measuring the prevalence of sepsis? And I think that's really where the big focus is for me, because I think that's now a key into understanding how we can start to improve what we do and then address how that might help us. Okay, so what is sepsis? Seems obvious when we use the word. I thought we might reflect on this historic slide, and you'll see that probably as best we can trace it back, the first use of the word sepsis was by the Hippocratic corpus in around 400 BC. So here's a little slide. There was sepsis and pepsis. So pepsis is how you make things. Sepsis was how you decay things. And that was the term used for the decay of organic matter. We move forward some hundreds of years to this word was used for blood rot, for diseases linked to purulent states, pussy states, and then the critical moment when Semmelweis discovered that hand washing reduced the incidence of puerperal sepsis. Why is that important? Well, I think that today many people are still using sepsis as a general term, and yet I think it has very specific meanings. We've had both colloquial and specific meanings to that. So I might jump forwards to this moment on the slide. 1991, when there was the American College of Chest Physicians and the Society of Critical Care Medicine consensus definitions for SIRS, such as an inflammatory response syndrome, and for sepsis. And the next key moment really comes forwards from there. We'll talk about those in a second, to really 2016, which was the Sepsis 3 guidelines. We'll talk about those for a definition. But you'll notice here that even before then, Chanu Ree, who is a public health physician in Harvard, started to be concerned about the definitions and how we could measure things based on those definitions. Oh, I'm not. Yeah. So here was this critical moment where there were definitions for sepsis and organ failure and for the use of innovative therapies in sepsis in 1992. And I just put up in the little box there to tell you that's a long time ago now. And for many people online, just you won't remember this, but that was when the first Cochrane Centre opened. And that was the same time when the text messaging prototype was first developed. So these things that we think are, a very long time ago, this was the moment, a very important moment. It turns out, I feel like I'm quite fortunate here that I bookended my career a little bit here, because around this time, I was a research fellow in sepsis and lung injury with Bill Sibbald, who's the senior author on this paper, at the end of this paper here. So I know exactly what was happening when these people came together. I knew Roger Bone quite well, and some of the other authors on this paper. These were not necessarily words that were being used from data. These were clinical words that they were trying to understand. And what I was doing in my research fellowship was trying to understand how the body responds, particularly how the blood vessels respond in every different organ system to sepsis. So we had sepsis models in there, and how some of the clinical interventions that we did with those blood vessels, and therefore how that would help us with treatment. But they defined sepsis as the systemic response to infection, severe sepsis as sepsis with organ dysfunction, septic shock as sepsis with shock, despite adequate fluid resuscitation, and SIRS as the systemic inflammatory syndrome. Now, those terms have subsequently no longer quite used for those meanings, and we'll come to that. But to give us an idea of where they started, and here's a diagram from that original paper. So you'll see there's a Venn diagram here. This was all infection up here, and sepsis was a subset of that infection. And then you had the systemic inflammatory syndrome, which might be caused by sepsis, but it also might be caused by trauma or burns or pancreatitis, other diseases like that. And if we had bacterial infection, you might have a bacteremia, so infection in the blood with bacteria. And not all of those cases produce sepsis. In other words, not all of those cases produced a syndrome of sepsis. You could have bacteria in the blood without that. Still meant you had infection, but didn't mean you had sepsis. The same for fungi, for parasites, viruses, and so forth. So if we jump forward to 2016, and that is relatively recent, there was the Sepsis 3 guidelines, and they're the current guidelines that we use if we're going to measure and talk about sepsis. Just to remind you, in 2016, when these guidelines were produced, Donald Trump, that was when he was first elected as President of the United States, and when Brexit happened. So they're important things that have happened in our recent past, but they're certainly some time ago now, 10 years ago. So I haven't heard that these guidelines are going to be, or these definitions are going to be revamped, but it's 10 years, so things might change. But the key moment here was that sepsis was defined as a life-threatening organ dysfunction caused by a dysregulated response to infection. And in the box in table 1 there, which is out of this JAMA paper, This is published in Journal of American Medical Association, which is a very prestigious journal. I think it's the highest circulation journal in the world. Up with that came a way to measure organ dysfunction using the SOFA score, or the sepsis related organ failure assessment score. And so you had to get a score for either for how you the oxygen in your blood relative to the inspired oxygen, to the platelet count, which was a measure of the coagulation system, to bilirubin, which was a measure of liver function, to the amount of cardiovascular support or blood pressure support that was being administered, a change in the conscious state as measured by the Glasgow Coma score, a change in the state of the function of the kidney through a measure called creatinine. You can also do this thing called a quick SOFA over here, but I think the primary piece was a SOFA score increase of more than 2. So while lots of people around the world were measuring how, and have been continue to measure how sepsis actually causes organ dysfunction, a whole other piece of work was, well, how common is it? And what do we know about how common it is? Who does it affect? And what's the impact of that? So on the left-hand side are some data about the incidence of sepsis and in-hospital mortality. And these data, and we'll come back to this because it's really the point of this talk, these data are based on the ICD-10 data. So these are things that our coders read out and put in to our notes. So they're very delayed, usually in actually appearing, but they end up looking for the word sepsis in the notes. Nevertheless, that has up till recently been a standard way that one would actually measure how these things happen. The top slide shows us that as you get older, the number of hospitalizations per admission increase with sepsis increases, and the mortality rate increases. The next slide shows us that the 2 most common causes of infection there are urinary tract and pneumonia. Not particularly surprising, but important to at least measure that. And that bacterial infection, particularly as you get older, is the dominant source of infection. Okay, so I want to address the next question, which is, why is it important to understand what sepsis is? Here's a very recent document. It's quite a large, 70 or 80 pages that's come out from the Australian Commission on Safety and Quality in Healthcare, which measured, again, using demographic data, the ICD-10 codes, how much sepsis happens in Australian hospitals and where it happens and what are the outcomes that occur. So it's a great document to look at and to read if you have a chance. But I think, one of the key highlights was that, 1 in 7 admissions has a diagnosis of sepsis. So it's common. The mortality rates you can start to see some of the health outcomes that we have with this, and some of the patients who are affected with this. So various groups are more likely to have poor outcomes. People with diabetes and so forth are likely to have poor outcomes. It's more likely that you have a hospital-acquired complication. It's more likely that you stay in hospital for longer than average, and so forth. So it's very common. But the methodology here was, as I said, ICD-10, which uses, and Lisa mentioned this, the explicit sepsis codes, and you can't probably see them on this slide, but coders have a specific way of coding for sepsis, and they have to read sepsis in the notes to do that. And these are called the explicit codes for sepsis. So they're explicitly documented. Somebody has written down sepsis. And I guess coming back to my previous point, it's not clear to me that all clinicians use sepsis in a clear way, and certainly most of them don't use it thinking of the Sepsis 3 guidelines. I think many of them think about it in a terminology that might have been used even before the College of Chest Physicians Society of Critical Care Medicine 1992 guidelines. They're almost in the Hippocratic sense of that's sepsis, rather than thinking about what are the strict definitions of it. In 2024, so just 18 months ago, this comes from a review paper in New England, Nuala Meyer and Hallie Prescott-Nuala. I think they're both American intensive care specialists located on the East Coast. Very interesting. And again, just reinforcing what we have. Infection plus life-threatening organ dysfunction is sepsis. The most common cause of in-hospital death in the United States. The most expensive cause of hospitalization in the United States. The pathogen only identified in 60 to 70% of cases. And here's a bit of the key, because it will depend on what definitions we use and how you define it, but a very high mortality, around 25 to 30%. So it depends. These are now become very specific definitions. The second part in terms of the importance is that sepsis is now one of the 15 plus, so more than 15 now, I think they're appearing maybe up to 20 clinical care indicators. The third reason to talk about sepsis, and Lyn will probably talk about some of this from her personal experience, is that it is not uncommon for us to recognise that we could improve the care of sepsis generally and with individuals. So one of the prominent ones was a young man in New York, and this came out of the Rory's rules, I think it's what it's colloquially called, came out of a sepsis regulation guidance document from the New York Medical Examiner with specifics about what you should do in terms of identifying sepsis in the state of New York. So it happened, you can see this was regulated in November 2018, and it's quite specific about what to do because unfortunately this young man died from sepsis, and it was thought that the recognition and therefore initiation of treatment was delayed, and we're pretty sure that the earlier you recognise and treat sepsis, the better the outcomes are. So there are, it's across everybody, but there are specific cases such as this one that are very important for us to understand and recognise. So how would we know if we were improving? And nothing particularly smart about this, was just, we might, maybe we would have better short-term outcomes, so reduced mortality from sepsis. In the ICU, we use a term standardised mortality, which means we can work out how sick somebody is and then get an assessment of how sick they are. Therefore, we can work out a standardised mortality. That's a term that we use in the ICU. So that helps us understand some of the elements of ICU and post-ICU care. We can look at the complications, the morbidity, the length of stay, and in the long term, a return to work. And I think Lisa mentioned is the quality of life, which can be quite pervasive. I think in understanding this and measuring quality, maybe one of the pathways that's very important is to think that we would have less deviation from best practice. What's our protocol? How do we deviate from that? And what we'll find if we look at it is that we don't do best practice as much as we think we do if we look at it very carefully. And I think that's a really important way for us to improve our care, because using that approach, we can become learning organisations and continue to improve what we do. So there is a South Australian adult sepsis pathway, and it's got this sort of golden hour idea of recognising sepsis. So, you can see there sepsis is time critical, recognising it, administering oxygen, obtaining intravenous access and blood cultures within 30 minutes, appropriate antibiotics and IV fluids within 60 minutes. These are the 2 pages of the pathway. You'll see that it was adapted from the New South Wales pathway. I think these are pretty, with minor changes, these are pretty universal now about these things. You know, could it be sepsis? How do you recognise it? Does the patient have signs of organ dysfunction? What should you do? The trouble we have at the moment is that if you want to understand what our compliance with that pathway is, as an example of how you might improve, we're hamstrung because we've got to have a stable definition of sepsis, and then we've got to be able to measure it. And you can either do that by auditing it, but you know, my real passion recently has been, could we develop a virtual registry so that we could actually continuously look at these things and work out what are we doing well, how can we improve, and how can we reduce deviation from that pathway if that's what we think is best practice. In the same vein, and this is some of the indicators from the sepsis clinical care standard, and if you look at these indicators, each one of them requires an understanding of the prevalence of sepsis in your organisation. The one I've highlighted there is the proportion of patients with sepsis who had a diagnosis of sepsis recorded on their discharge summary. And I'm going to suggest to you that's a very complex piece, because next few slides will show you that depending on how you define sepsis, it may not be, we may not use the words when we actually think we've got sepsis. And sometimes we use the words when we don't think we've got sepsis. So again, this is about how you define these things and how you can actually measure prevalence. Okay. Here's a suggested way that you might find a good prevalence marker. And I've said it's about prevalence, it's about how you capture it, and about the timing of onset. So the explicit code for sepsis is what we see in when our coders read through a clinical chart through the EMR and they find the word sepsis, it fits up with their coding definitions. That's called explicit. And I'll show you the data around this, but actually that's an unstable prevalence marker. That has changed over time, and it's changed because the more we talk about sepsis, the more we write it in the notes, when maybe the number of cases don't change. So it's quite unstable. The capture is delayed because it's got to be a coded piece, and it doesn't help us with the timing of the onset. There's another definition that people have used called the implicit code, which is, this is where you get a code for infection. So that's different to a code for sepsis. So you have a code for sepsis, and if you can find an organ dysfunction, then you think that it's implicit. And it turns out that that's also an unstable prevalence marker. It's also delayed post-coding, and you can't infer the time from the organ dysfunction because it might be due to the infection or not. The third method that's been used is the explicit plus implicit, the combined method, and that has the same problems as the previous ones. The fourth one, which is, and again, this is just what we call it, but at least we're starting to call it, and this is the adult sepsis event marker, which the Centre for Disease Control have been suggesting we use for some time now. And basically, it is an EMR stable way of, or an EMR accessible way of sepsis 3 coding. And that turns out it's stable over time. You can get it from the EMR, so it's near time. You can get it within, you can actually capture the data within a couple of days of the episode. And we can actually capture the time of onset by the time of the first blood culture or by the initiation of antibiotics. So it has some advantages. So very quickly, I'll just notice time is running on us, but I'll keep working. So here's some of the data, and you'll see that these people have looked at trends in sepsis in the United States and looked at explicit the explicit codes, the implicit codes, the combined codes, and the CDC codes. So this top line here, which shows you over time in the United States, the explicit plus implicit was the highest and almost doubled over this 10-year period. And you'll see most of this, and here is the lowest, is the explicit, but it's also increased significantly over 10 years. What's important to understand is that the positive blood cultures in American hospitals decrease over this time. So these data, I suggest to you, tell us that both explicit and the explicit plus implicit and the implicit coding are unstable over time and are not good prevalence markers for us to use. Much more stable in the middle is the CDC coding because it doesn't rely on a coder getting those terms for us. And so it's not influenced by what we say and what we do. It's influenced by what's actually occurring at the bedside. Same sort of data here, but again, looking at mortality. So in red is the explicit sepsis codes at the top here. And one could interpret this as a significant improvement in our outcomes in that the mortality has reduced over time. But if you combine it with the previous slide or the slide here showing the prevalence increasing over time, it's probably no real change. The same thing goes for the explicit and implicit codes here in green. And you can see again, using the adult sepsis event marker, it's relatively stable over time. So people have suggested, and I think I would suggest that that is a more useful marker to see whether we've got changes over time and what is happening in our hospitals as we improve. So this marker goes back to the sepsis 3, says suspicion of infection. So if you've got a suspicion of infection, it means that somebody's probably obtained a blood culture and or started a new antibiotic. So you need, that's a suspicion of infection. And then it uses the sepsis 3 definitions in an EMR format. So we can extract these straight out of the EMR pretty quickly. You know, it can be done almost real time of organ dysfunction. So that's pretty straightforward, and it gives you a stable prevalence marker. Okay, so what we have done, and I'll just go through these slowly. This was some initial work that we did at SALHN, was with the help of Rachel Needle and Hardeep Singh, who really did the work on this. I was just sort of the guy at the back pushing. We got into the EMR and ended up with a Power BI report that can be updated as regularly as you like. And you'll see that this was coded sepsis and this was detected sepsis. So coded sepsis, which is in red, is what you got from the ICD-10 codes. And the detected sepsis, which could be much more, which is using the adult onset event marker in this Venn diagram, you'll see that you're looking at slightly different groups of patients. There's some overlap, but not as much overlap as one might want. So this was the number of cases. This is just in a 12-month period, so a high number of cases in this 12-month period, 1266 cases out of this many separations. We're just doing a little bit of harmonising with the Commission around mortality, so I've blacked out the mortality here so that we don't get too confused. We can, within this, because within that code, there's a time cutoff. In other words, if you develop sepsis within 48 hours of admission, that's called community-acquired sepsis. Otherwise, it's hospital-acquired sepsis. We can actually select out the cases that are community or hospital-acquired as well. And that's interesting because in our data here, close to 40%, I think it was 39.6% of cases are hospital-acquired sepsis. So it's common. And we were only measuring on this, in this data set, first episode of sepsis, not subsequent ones, just the first episode of sepsis. So very common hospital-acquired sepsis as well. Also in here, we can start to break it down to the divisions. So whether we have 5 major clinical divisions at SALHN, each network is different, of course, but in medicine was cardiac critical care was very high prevalence of sepsis, mental health was very few. Surprising significant number occurring in our rehabilitation, aged and palliative care component, the organisation, some in surgery and perioperative, but they tended to be admitted primarily under medicine if sepsis was the problem, and few in women's and children's. You could break it down and look here over on this part to exactly the service that you're looking for. So if you wanted to look what was happening in a particular service, maybe you wanted to see sepsis rates in the heart failure service or in oncology or in hematology, you can break it down because, you know, that's the way the data is available through the EMR. The final slide I thought was of some interest to you, and I didn't focus on this, but this on the bottom here in these 2 bar charts, we're comparing the separations between the coded sepsis, which is the lower number, and the detected sepsis, which is the higher number. And over here is the length of stay. And you can see, so this blue line is the average length of stay for all patients at SALHN in this period of time. And there looks like there was a peak over this 3 months of winter. And in fact, if you look at the detected sepsis using that old sepsis event marker, it's quite a significant peak, which would be the equivalent of around 25 to 30 hospital beds for 3 months. So this actually occurred in hospital-acquired sepsis. We haven't had the opportunity to explore that any further, but I think it demonstrates that you could be extremely rich in understand what is going on in our organisations at various times that put pressure on our system, as well as how we can improve our care in those circumstances. My last slide, so apologies, I might have gone a few minutes over time. So what I've tried to do is talk about what is sepsis and explain that I think it is quite important that we use strict definitions so that we can have stable markers. We've talked about why it's important, how we'd know if we're improving, and you need a proper stable definition to do that. How you would measure prevalence has really been the subject of the talk. And how does that help? Well, I think once you've got stable measures, we can start to use the concepts of a learning health system. So in here, we've got a question from our community, and with many questions around our outcomes around sepsis, which I think stagger people how poor the outcomes are when we measure them properly. But we need data to do that. Once we've got data, and if we have it, the better the data we have, we can ask more questions. We can then start to work out what is it that's happening. We can then get into, at the first instance, things like plan, do, study, act, so the implementation of continuous improvement. But that also would allow us to study things. To study decision support, to study behavioural nudges. If we could predict sepsis, would that influence our behaviour? To embed clinical trials, and you can do this. Some of the EMRs are now, Epic, I know, has embedded clinical trials are available within that. We assess the impact, we see if we sustain the improvement, but we're measuring all the time. We're measuring to see how we're going, see if we're improving across the board. So, look, thank you very much. Sorry I've taken a couple of moments longer than maybe I should have, but happy to take some questions at the end of the seminar.
Okay, hi. I'm a sepsis survivor. You could say that sepsis and post-sepsis syndrome are my raison d'etre. Whenever they're mentioned in the hallowed halls of CIH, I get a little ping in my ear, and I'm on the phone to them before they can lift the phone to call me. I am nearly always involved with CIH when sepsis is being discussed because I'm so passionate about it. When I heard that this project was going ahead, I couldn't wait to be invited or hope to be invited. My sepsis journey has led me to be involved in projects I would never have thought I would be considered for. I serve as the consumer advisor on the Global Steering Committee of a huge international trial called the SNAP trial, which is led by 2 researchers from the Doherty Institute in Melbourne. When they advertised for a consumer to be on their global steering committee, I was very excited to be chosen on the shortlist. And when we had our Zoom meeting, and halfway through the interview, one of the researchers said, have we turned you off yet? My response was an incredulous, have I got the job? And the answer was a resounding yes. I've learned so much from Professor Stephen Tong and Josh Davies, but I'm happy to say that I've taught them a few things too. When we were talking about the trial, which is the Staph aureus Network Adaptive Platform Trial, aka SNAP, see how these words roll off my tongue now, as though I've been doing it all my life? I've become very good at looking as though I know what all the long words mean. I noticed that the sepsis survivors were only being followed up for 90 days. And I asked why they weren't followed up for longer, as I knew many people were leaving the hospital with a range of symptoms that couldn't be explained by clinicians as being something to do with sepsis. So we were being sent off with things like, oh, don't worry, dear, you've been very ill. It's going to take you a long while to get over this. You get little hiccups along the way, but you'll be fine. And these hiccups were things like nightmares, flashbacks, trauma, brain fog, body aches and pains, lethargy. I could go on and on. So when I said the words post-sepsis syndrome, Steve and Josh said to me, what's that? So for 4 years, I told them every chance that I had. And I'm so proud and happy to say that last year they put in a grant application for $7 million to research post-sepsis syndrome in patients like me who'd been severely ill with sepsis but never had to go to ICU. There's been some research on sepsis survivors who have been in ICU, but not for the many people who are battling with it for these reasons. So I'm now on the Global Steering Committee of the SNAP long-term follow-up trial as a deliriously happy consumer advisor. So now I finish showing off, I'll tell you how my sepsis journey was 11 years ago in Adelaide. I woke up one morning feeling really unwell. Nothing I could put my finger on, but I just had this strange feeling that I was dying. And when I tried to get out of bed, I put my left leg to the floor and I screamed. As soon as I tried to weight bear on that left leg, the most excruciating pain I can ever remember, and yes, ladies, it was worse than labour pains, I can tell you, shot up my left leg and into my spine. I turned to my husband and said, I think you better call an ambulance. And he looked back at me and said, no, you ought to do it. They'll want to talk to you. So after some rather terse and very rude words hurled at his hastily escaping back, I did. They arrived virtually straight away and they whisked me off to a large public hospital. They were worried about me as I was yelling every time we went over a bump in the road because the pain was so bad, even with the lovely green whistle. And when we arrived at the hospital, they hung around until they were happy that I was being seen by somebody and not just being left to lie on the bed. I saw 2 delightful young student doctors who did a urine screen, a chest x-ray, but no blood test. I couldn't understand that one. 2 hours later, they came back smiling and said I had a virus, gave me some paracetamol and said, you can go home. They'd run my husband to come and pick me up. And I said, but I can't walk. They said, you'll be fine. You've just got a virus, you'll be fine. And off they went. So then the nurse came along and said, you can go home. And I said, but I can't walk. And she said, but they told you can go home. And I said, yes, but I need a wheelchair to take me to the car park. Oh, she said, I'm not allowed to take that out of VV. And I said, well, okay, I'll just lay here because I can't walk. So with very bad grace, she wheeled me out to the car park and I waited for my husband to arrive. His first words were, why are you out here? You need to be admitted. Why didn't you ask to see somebody more senior? And I was crying at this stage because I felt so ill. And I said, I just wanted to go home and go to bed. So he did what would be the best thing he's ever done in his life for me. He said, I'm not happy. I'm taking you to our GP on the way home. So we went to see our GP. He gave me some antibiotics and said, I want to see you tomorrow or sooner if you get worse tonight. Take these and I definitely need to see you tomorrow, if not before. So I went home, started the antibiotics, and the next day I was considerably worse. So my husband took me back to surgery. So Peter, my GP, took one look at me and said to my husband, take it to the North Eastern community. hospital. I have admitting rights there. There'll be 2 doctors waiting for her. I'm ringing them now. So off we went. And I spent the next 4 weeks there on IV antibiotics. I don't remember much about the first week. I was hallucinating. And you know those tiles on the hospital ceilings? In my mind, they were on the wall at the foot of my bed, and everyone had a different head in it. And the nurses told me later they would come in and find out who I was talking to. And I'd say, oh, Elton John or the Queen or the Prime Minister, you know, you name it, I had their ear. So it's no wonder I was so ill. I had a Staph aureus bloodstream infection and a massive epidural abscess from T1 to L6. And this caused my body to respond violently with sepsis. On the second week of my stay, my GP and 2 doctors looking after me all came to see me at different times and all had the same message. If you had got to this hospital 24 hours later, you would be dead. And that was a very sobering thought. It really blew my mind. And I remember on my 3rd week, slowly walking around the ward, hanging onto the handrail as I passed the nurses' station. And I heard one nurse say to the other, this is what nursing is all about. Seeing somebody come in so very, very ill, and then to see them walking away, trying to get their legs back so they can get a newspaper every morning. So when I eventually got home, have I still got time to go on, or are we running late? I've got another few minutes. Is that okay? Okay, thanks. When I got home, I was seeing my infection specialist for every 2 to 3 weeks for 18 months. And every time I saw him, he would say to me, you're so lucky, you are so lucky. And I could never work out why. Until I was invited to join the consumer group run by the George Institute for Sepsis survivors. And at my first meeting, I met 3 adults who all were quadruple amputees, and one mother of a beautiful little girl who had sepsis at 3 and is a quadruple amputee also. And then I knew why. So now we come to the possible long-term effects of sepsis. I remember being in the supermarket with my husband, who wandered off as usual, and I was trying to reach a particular pack of Brazzini. There was a tall man standing behind me, and I asked him, excuse me, would you be kind enough to pass me? And then the words were in my head, but I could not get them out of my mouth. I felt embarrassed and so stupid. And I've been buying those breadsticks for donkey's years, knew the name off by heart, but I just couldn't get those words out of my mouth. And similar episodes happen quite often. It was very scary. I eventually found a Facebook page for sepsis survivors run by Fiona Gray. We're now very firm friends. And the next day she joined the Health Consumers Advisory Network that I chair. We formed to try and keep the Spirit of Health Consumers Alliance alive. And I fell on her and found out more than I had been able to find out about post-sepsis syndrome since I started. We catch up every now and again, and through TGI, the George Institute meetings, and through CIH. And I know now why I keep dreaming about people putting bags of ice on my head. I told my husband about it, and he said, well, they were. Your temperature was so high, and they were trying to bring it down. And that's just one of the problems of post-sepsis syndrome. Courtesy of sepsis, the gift that keeps on giving. Thank you.
I just want to say thank you to both Andrew and Lyn for presenting today and taking the time out of their day to share their research, but also their personal stories.